a state-of-the-art literature review by Francisco Nappi in the Department of Cardiac Surgery in France. Ischemic mitral regurgitation is a frequent complication of left ventricular global or regional pathological remodeling due to chronic coronary artery disease. Ischemic mitral regurgitation is defined as mitral regurgitation caused by chronic changes of LV structure and function due to ischemic heart disease. It is not a valve disease but presents the valvular consequence of increased tethering forces and reduced closing forces. It is reported in approximately one-fifth of patients following acute myocardial infarction and one half of those with congestive heart failure. Ischemic mitral regurgitation is a frequent complication of coronary artery disease and it worsens the prognosis. Myocardial infarction of the segments underlying the papillary muscles, typically a lateral or inferior infarct, results in remodeling of the region of the ventricle. Here we can see posterior and apical displacement of posterior medial papillary muscle, typically seen with inferolateral akinesia or dyskinesia at the base of the left ventricle. It causes tethering of posterior mitral leaflet leading to coaptation defect and posterior dilated mitral regurgitation jet. Same in the figure 2, mitral regurgitation jet is seen in the posteromedial commissure. Typically, P2, P3 segments are tethered, causing the appearance of pseudoprolapse A2, A3 segments of the anterior mitral leaflet. Following current guidelines, the surgical community largely endorses the use of mitral valve replacement for secondary ischemic mitral regurgitation, with most patients undergoing cord-sparing surgery to replace the ischemic mitral valve. Use of restrictive mitral annuloplasty has progressively decreased over the past 8 years and it was introduced in the 1980s. However, its use has declined because the randomized clinical trials by Cardiothoracic Surgical Trials Network (CTS-NET) reported poor outcomes. However, the use of mitral glymph device to perform H2H transcatheter repair, which has expanded the range of mechanical interventions are now available, remains controversial due to conflicting evidence regarding the benefits in terms of efficacy and safety. Moving on to methods, this seminar presents a narrative review based on author's knowledge. The literature search was conducted using Permanent Medline and Embase. The literature review comprised full articles of randomized control trials, propensity match observational series, meta-analysis, and unmatched OS published in the past 10 years up to end of March 2024. Key international guidelines and expert consensus reports were reviewed to categorize documents based on their relevance to clinical and echocardiographic diagnosis, classification, and management, treatment strategies, long-term follow-up, and risk factors. Secondary ischemic mitral regurgitation is a complex disorder with limited randomized studies available on optimal treatment. In some cases, urgent treatment may be necessary due to rapid deterioration of ventricular function. This can limit the possibility of designing randomized controlled trials. Patient must be at least 18 years of age. Patient must have undergone surgical procedure including mitral valve replacement, mitral valve repair, or transcatheter mitral valve therapy. And these were the inclusion criteria for these articles. Assessment of different procedures. The literature currently uses terms functional mitral regurgitation or secondary mitral regurgitation. The condition may be caused by either ischemic or non-ischemic factors. In this seminar, the term used to describe pathology involving the mitral valve is secondary ischemic mitral regurgitation. However, some reports also describe patients affected by non-ischemic secondary mitral regurgitation, which were compared with those who had secondary ischemic mitral regurgitation. The presented evidence is from the most comprehensive reported data series on MVR and mitral repair, which evaluates different mitral repair techniques, their reported outcomes, indications, procedural use in clinical practice, clinical proofs, and limitations. The report also includes follow-up of patients with several left ventricular function dysfunction who were indicated to receive left ventricular assist device. Yeah. So, what are the various treatment options for secondary mitral regurgitation? Uh, these can be divided into two parts. One who don't require a CBG or in which a CBG might be needed. In case of mild MR, usually CABG is only needed. Moderate MR, CABG plus this restricted mitral annuloplasty or a surgical valve repair might be needed. And severe MR, CABG plus valve repair might is needed. If if the MR is persistent, moderate to severe, then it can be divided into the four categories: 1A, 1B, 1C, and 2A. 1A including lower risk of recurrent MR after surgery with MV repair. 2A including high risk of recurrent MR after surgery with MV repair. 1B is ineligible for surgery or MV repair, and 1C is severe LV dysfunction. The treatment indicated for 1A is restricted mitral annuloplasty, that is downsizing by one or two ring size, and complete or semi-rigid ring can be used. For 2A, which is high risk recurrent mitral regurgitation after surgery, MVR, that is mitral valve replacement, usually caudal sparing technique, is used. And for ineligible for surgery, mitral clep is used. And for severe LV dysfunction, usually LVAD or palliative medical management is used. Moving on to mitral valve replacement. In recent years, mitral valve repair has become more popular than replacement, but however, in recent randomized controlled trials from CTS net suggested that replacement is superior for patients with severe ischemic mitral regurgitation. The rate of recurrent, moderate, or severe mitral regurgitation over 2 years was higher in a repair group than in the replacement group, resulting in a higher incidence of heart failure and repeat hospital admissions. Valve replacement may be more beneficial than valve repair in cases of secondary MR, as repairs are less durable in these cases. Uh, re- Restrictive annuloplasty was confidently performed using an approved complete rigid or semi-rigid annuloplasty ring that was downsized one or two size to correct for annular dilatation. MR may persist or recur after a restrictive mitral annuloplasty due to augmented leaflet tethering causing by the anterior displacement of the posterior leaflet as well as progressive global or localized LV remodeling. Caudal sparing mitral valve replacement may be superior alternative to downsized annuloplasty repair for patients with coronary artery disease or chronic severe secondary MR due to LV systolic dysfunction less than 50% who require mitral valve surgery because of severe symptoms like NYHA class 3, class 4, or that persists despite best medical therapy for heart failure. American College of Cardiology, American Heart Association classifies the recommendation for surgical valve replacement as class of recommendation 2B. Nearly 4 decades ago, a seminal paper by David et al. Demonstrated that integrity with continuity between the mitral annulus, the LV wall through the leaflets, the caudal tendency, and the uh, and the uh, and the uh, papillary muscle is essential for left ventricular function after mitral valve surgery. Procedural use in clinical practice. The use of complete caudal preservation surgery as opposed to posterior leaflet only results in a superior long-term reduction in the LV chamber dimensions and systolic afterload. Several individual studies have documented various drawbacks in patients who received partial caudal preservation compared to those who underwent mitral valve repair. These disadvantages included higher operative mortality, worse LV function, and poor long-term survival. The unique morphological characteristics likely account for the superior effectiveness of complete caudal sparing preservation, improving wall motion and apical and diaphragmatic regions of the left ventricle. Preserving the entire subvalvular apparatus may lead to sustained and incremental decline in left ventricular and diastolic volume at the postoperative discharge. After 1 year, the decrease was seen to be more significant compared to partial preservation. Furthermore, in comparison to partial preservation, patients who underwent complete caudal preservation had further decrease in left ventricular and systolic volume over time, whereas no significant differences were noted in patients who underwent partial caudal preservation. Clinical proofs. Only one RCT has been published to assess the outcomes of complete caudal preservation versus mitral valve repair. Only one RCT has been published to assess the outcomes of complete uh, uh, left ventricular reverse remodeling, defined as left ventricular and systolic volume at 1 year after randomization, was the primary endpoint. At the 2 year interim analysis, there was no meaningful group difference in LV reverse remodeling. The outcome of the CTS net trial beyond 2 years will not be published due to the study design's limited follow-up period, which did not exceed 2 years. Currently, there is considerable body of comprehensive data available to advocate the use of caudal preserving mitral valve replacement surgery as it has shown to provide additional benefit on MR recurrence over mitral valve repair. However, near a decade ago, a systematic review of matched cohorts of 600 patients who underwent mitral valve repair or mitral valve replacement showed that long-term risk of death was 35% greater in replacement arm versus the repair arm. For those who received mitral valve repair, the survival rate was 81%, where it was 55% for those who received valve replacement. Limitations. The main concern regarding the surgical procedure of mitral valve replacement is the potential for increased risk of impaired postoperative ejection performance when a replacement is performed without sparing the valve apparatus at the time of ischemic mitral valve regurgitant surgery. This pathophysiology is related to sudden increase in systolic wall stress resulting in loss of the low impedance pathway or for ejection into the left atrium and ventricular dysfunction due to fracture of the mitral valve apparatus. Royce et al. Demonstrated that mitral caudal preservation at the time of replacement resulted in substantial reduction in the incidence of left ventricle end diastolic and end systolic volume reduction and marked decrease in LV end diastolic wall stress in the caudal preservation group. The ejection fraction remained constant and after mitral valve surgery in patients who underwent caudal sparing surgery, but was significantly reduced in patients who did not undergo caudal sparing surgery. However, the occurrence of severe ventricular dysfunction can be considerably lowered by careful patient eligibility and selection of appropriate surgical techniques for ischemic mitral regurgitant repair. Mishler also found that mitral valve tenting area of more than 3.1 centimeter square, but not the left ventricular end-diastolic diameter of more than 64 mm or left ventricular end-diastolic dimension of more than 54 mm greatly decreased the risk of sustained or repeated MR when caudal sparing replacement was performed. Moving on to mitral valve repair procedures, restricted mitral valve annuloplasty. RMA was pioneered in mitral valve surgery in 1980s and has been extensively applied by the surgical world, treating patients with moderate to severe ischemic and non-ischemic mitral valve regurgitation. Secondary ischemic mitral valve regurgitation is typically associated with regional inferior wall motion abnormalities, resulting in posterior leaflet tethering and posterior directed mitral regurgitation. The purpose of restrictive mitral annuloplasty is to decrease the anteroposterior diameter by tightening the leaflets, thereby minimizing the tenting area and favoring the restoration of normal coaptation length. Hence, removing mitral regurgitation and reducing the size of the left ventricle can lead to decrease in stress on the LV wall, resulting in enhancement of LV reverse remodeling. The use of restricted mitral annuloplasty combined with coronary artery bypass grafting in patients with moderate secondary ischemic mitral regurgitation is still a topic of ongoing controversy. Penica et al. Showed that viable myocardium can be indicated by improvements in global regional wall motion as well as reverse LV remodeling after CABG alone. The results of CTS NET study reinforce the importance of CABG and the preservance of viable myocardium, as patients who did not receive CABG had no improvement in regional wall motion. Thus, restricted mitral annuloplasty proved to be ineffective, hindering the leaflets from achieving the necessary coaptation zone to reduce uh, tenting height and area. Procedural use in clinical practice. The commonly accepted practice in restricted mitral annuloplasty is to downsize by two size ring sizes. For example, using size 28 when measuring the size 32. The choice between the rigid or partial bands or flexible complete rings as well as overcorrection by undersizing can impact mitral regurgitation recurrence rates. Although there is some evidence to support a higher incidence of recurrent MR in patients undergoing partial band or flexible full ring repair. Recurrent mitral regurgitant rates remains high in patients undergoing full rigid ring repair. Generally, uh, restricted mitral annuloplasty involves downsizing the ring by two sizes. If left ventricular ejection diameter is less than 60 mm and left ventricular ejection systolic diameter is less than 55 mm. However, recent research has shown that this approach may not be appropriate due to impact of RMA on the spatial relaxation between the ventricle and the mitral annulus. The use of restricted mitral annuloplasty can exacerbate the teetering of the posterior leaflet and further disrupt this ischemia-induced abnormal geometric spatial relationship. CTS net investigators suggested that the ratio of left ventricular ejection systolic diameter to prostatic annuloplasty ring size may be useful in assessing the risk of persistent or recurrent mitral regurgitation. According to most comprehensive echocardiographic studies, recurrence of moderate or more mitral regurgitant in patient ranges from 32.6% at 6 months to 56.8% at 24 months and 55.9% at 5 years. It is commonly accepted that recurrence of mitral regurgitation should be observed in patients with centrally directed or multiple jets, a higher degree of LV enlargement, symmetric interolateral tethering, the presence of basal aneurysm dyskinesis, a coaptation height of 11 mm or more, and a posterior leaflet angle of greater than 45 degree. Trials with follow-up periods longer than 5 years have consistently reported a substantially higher rate of mitral regurgitant recurrence for undersized mitral valve repairs compared to mitral valve repairs. Recently, Vishwi et al. Performed a propensity match analysis of patients with secondary ischemic MR versus non-ischemic secondary mitral regurgitation. Survival was worse with systemic secondary ischemic mitral regurgitation versus non-ischemic secondary mitral regurgitation, although similar repair durability was observed. These findings are consistent with those reported in the CTS-NET study for patients who received restricted mitral annuloplasty with lower preoperative left ventricular ejection systolic volume. At the 2-year follow-up, 74 patients were enrolled in the CTS-NET trial and had severe ischemic mitral regurgitation, but no MR recurrence had left ventricles that were significantly smaller compared to those with recurrent MR post restricted mitral annuloplasty alone. The left ventricular ejection systolic volume measures remained lower than those who underwent surgical mitral replacement. One limitation of restricted mitral annuloplasty is the significant geometric deformation of the left ventricle and the associated increased left tethering with adverse mitral remodeling. Some studies have consistently demonstrated that uh, uh, restricted mitral annuloplasty is inadvisable whether performed with one or two sizes. CAPG and moderate secondary ischemic mitral regurgitation. At present, there is no widely accepted surgical standard of care for moderate ischemic mitral regurgitation at the time of CABG, and there is no consensus on a single approach. Two contrasting views exist. Some experts believe that revascularization alone can lead to lower rates of mitral regurgitation in patients with moderate moderate ischemic mitral regurgitation. This is based on the observation that regional and global LV function and geometry are significantly enhanced after CABG. The opponents of this approach argue that revascularization alone can reduce rate of uh, mitral regurgitation. In this way, additional adverse remodeling may be prevented and the subsequent heart failure is likely to be reduced. Procedural use in clinical practice. The results of studies comparing CABG with or without restricted mitral annuloplasty are often inconsistent and limited by methodological or sample size limitations. Although some studies have suggested that restricted mitral annuloplasty may improve event-free survival, the evidence is not conclusive. CABG alone versus CABG plus restricted mitral annuloplasty in moderate ischemic mitral regurgitation with well-defined MR measurement criteria has been compared in 4 recent RCTs. At 12 months, there were no significant changes in echocardiographic measures of residual MR. In addition, there was no significant difference in improvements between CABG alone and combined strategy as evaluated by Minnesota Quality of Life score and brain natriuretic peptide measurements. A study sponsored by National Heart, Lung and Blood Institute CTSNet compared CABG alone with CABG and restricted manual angioplasty in 301 consecutive patients. Patients receiving the combination procedure RMA group had substantially lower MR recurrence rates in at 1 and 2 years compared to CABG alone, with no worsening to severe MR in RMA group. No substantial improvement in 2 year mortality was observed in patients who received combination of CABG and RMA over those who received CABG alone. Long-term follow-up results from the randomized trials Point and RHYME have demonstrated benefits of restricted mitral annuloplasty at the time of CABG in preventing further progression of secondary ischemic mitral regurgitation, mitral reintervention, and LV remodeling. Patients who underwent combined CABG with mitral valve surgery had significantly lower incidence of moderate to severe MR at follow-up. It is worth noting that while there is no conclusive evidence to suggest mitral valve surgery alters the natural course of dilated ischemic cardiomyopathy or improves survival rates, the use of restricted mitral annuloplasty during mitral valve surgery may result in severe complications due to increased posterior leaflet teethering. Following evidence of increasingly severe leaflet teethering due to anterior displacement of the posterior leaflet and ongoing adverse global and localized LV remodeling, concerns have been raised about the risk of re-escalation of mitral regurgitation associated with overcorrected restricted mitral annuloplasty repair. This is a decision-making algorithm for surgical treatment of moderate to severe secondary ischemic mitral regurgitation with or without the use of CABG. So, if CABG is needed and a mild grade of MR is there, then we can proceed with CABG only. Moderate MR, CABG, in moderate MR, CABG without array in small LV and in large LV, both we have to proceed with mitral CABG plus mitral valve repair or replacement. And in severe MR, CABG with mitral valve replacement is recommended. Subvalvular procedures. In order to restore the function and configuration of the subvalvular apparatus, subvalvular procedures often used in addition to annuloplasty. The primary impact of subvalvular procedure is to relieve the teethering forces applied to both leaflets of the mitral valve due to lateral and posterior displacements of the papillary muscles. In contrast to restricted mitral annuloplasty, which may have indirect effect on restoring LV geometry through conductive reverse remodeling. Valvular procedures or repairs provides a direct effect on improving LV geometry. 3 techniques with possible variants are reviewed here. The papillary muscle approximation, the papillary muscle relocation, and the ring plus ring procedure. The aim of performing subvalvular repair in conjunction with restricted mitral annuloplasty is not only to ensure direct improvement of the interpapillary muscle distance, but also to monitor the overcorrection of the annuloplasty to prevent the complication of mitral valve stenosis. The importance of movement of papillary muscles in three directions, apical, lateral, and posterior, has been widely recognized by the community of cardiologists and cardiac surgeons, with the result that it guides both the indication for surgery and the choice of treatment. As both parietal posterolateral papillary muscle displacement is the prevailing pathology leading to apical leaflet teethering in secondary ischemic mitral regurgitation. Papillary muscle approximation, as originally reported by Haves et al., the reapproachment of the papillary muscle was carried out by means of 4 Gottes prosthesis. The papillary muscles were fully approximated by guiding the prosthesis through the ventricular trabeculae. Two key aspects were highlighted: the anatomical relevance of the papillary muscles and the degree of approximation based on the type of tethering and the extent of ventricular enlargement. The data showed a slightly higher percentage of surviving patients with relapsed severe mitral regurgitation in restricted mitral annuloplasty group compared to uh, posterior mitral annuloplasty group at the 5-year follow-up. These results demonstrated the effectiveness of RMA plus PMA in improving patient outcomes and suggested that it may be preferable treatment option. The effect of combined procedure of on the proportion of patients with higher number of events for MACE at both the valvular and subvalvular levels were surprising. The controversy surrounding the use of two-stage MV repair consisting of uh, posterior mitral annuloplasty or restricted mitral and manual mitral annuloplasty procedures are warranted when the outcomes are examined in details. Indeed, a 5-year follow-up, we observed that rate of rehospitalization for heart failure of 23.8% and a rate of moderate to severe MR of 27%. Two-stage mitral repair surgery including surgical valve replacement procedure is recommended to address severe address left ventricular remodeling in patients with dilated left ventricle, extensive scar tissue formation, dyskinesia or basal aneurysm. Papillary muscle relocation. In 2000, Lyle Cohen conducted an initial experiment that Cohen et al. Were the first to describe the widespread use of posteromedial papillary muscle relocation in 18 patients with transmural infraction of the inferior wall and moderate to severe secondary ischemic mitral regurgitations. Since then, the relocation of the papillary muscle has been used in clinical routine. The procedure requires suturing of fibrous portion of the posterior papillary muscle tip twice using thioprolene suture to bring the posteromedial papillary muscle tip closer to the annulus, bringing the suture down to the mitral annulus just posterior to the right fibrous trigon. Identifying the final position of the tip of the posterior papillary muscle by locating the point at which the leaflets coaptation in the plane of the mitral annulus. Paul Shuttle recently employed an innovative approach to posteromedial papillary muscle relocation consisting of the following key stages. Both papillary muscles are realigned apicolaterally in standardized manner. Their sutures are fixed on the posterior side of the annuloplasty ring. The procedure is systematically applied in three-dimensional endoscopic or mini thoracotomy setting. The landmark trial showed no short-term mortality at 2 months and no need for reintervention with subvalvular papillary muscle relocation procedure. In a study of 110 patients with over 48 months of follow, there was no difference in overall 5-year freedom from cardiac-related death. A total of 101 patients were studied in a single RCT. It compared two-stage mitral valve repair using combined papillary muscle relocation and restricted mitral annuloplasty with isolated restricted mitral annuloplasty procedure. During a maximum follow-up period of 1 year, the 51 patients who underwent a two-stage mitral valve repair with uh, papillary muscle relocation procedure achieved a significantly better 1-year survival rate than those of whose ischemic mitral regurgitation was treated with single-stage mitral valve repair, including isolated restricted mitral annuloplasty. Additionally, they showed significant trend towards better event-free mitral regurgitant recurrence. The result of reformed MR trial registry are promising for establishing a standard approach to two-stage valve and subvalvular repair. In a multi-center setting, this study defined the outcomes of treating secondary ischemic mitral regurgitation with combined papillary muscle relocation and ring annuloplasty. It aims to enhance comprehension of the limitations of subannular repair procedures in treating patients with type 3 secondary ischemic mitral regurgitation. Then moving on to limitations, there have been extensive studies of the biochemical profile of the surgical valve replacement, and the use of papillary muscle approximation or relocation has been shown to have no additional preoperative risk. However, papillary muscle relocation may have potential adverse biomechanical effects unlike papillary muscle approximation. Montabi et al. Demonstrated that relocating the papillary muscle may restrict the mitral valve if it is directed only towards the posterior leaflet, causing tilting effect on the posterior annulus and increasing its posterior tethering. In the larger series by Fatosh et al. And Posh et al., it was found that papillary muscle relocation was effective only when combined with a non-restrictive annuloplasty. Ring plus string procedure. The ring and string procedure, which have been adopted in mitral valve surgery since the 2009 by Langer, consists of use of restricted mitral annuloplasty ring combined with papillary muscle repositioning, that is the string. This the concerns about the extent of occurrence of recurrent mitral regurgitation due to LV remodeling, for which uh, and tenting height is one of the more easily determined quantitative parameters, have been elevated by the evidence that tenting height exceeding 10 mm. It has been suggested that complementing uh, restricted mitral annuloplasty with papillary muscle repositioning may offer potential benefits for patients with secondary mitral regurgitation greater than grade 3 or tenting height greater than 10 mm. An undersized ring, one or two sizes smaller than the intertrigonal distance, is used in restricted mitral annuloplasty. The procedure begins with a horizontal aortotomy followed by passing a double-armed Teflon plated 4O expanded polytetrafluoroethylene PTFE Gore-Tex suture string through the head of the papillary muscles. Next, the suture is threaded from the LV cavity through the aortomitral continuity below the commissure between the non-coronary and left coronary aortic cuff and then exteriorized. For patients with non-ischemic cardiomyopathy or ischemic mitral regurgitation characterized by global LV remodeling, it is more appropriate to use two strings, one for each papillary muscle. The main problem with this procedure is that the mitral subvalvular apparatus is not fully exposed with the transverse aortotomy, which can be a limiting factor. While Langer et al. Have reported positive results regarding the efficacy and safety of this technique, it is important to note that these findings may not be representative of a larger controlled group of patients followed over time. Although Langer et al. Have published results indicating that this technique is useful and safe, it is important to note that this type of approach may not be representative of larger series of controlled patients with long-term follow-up. Mitral valve leaflet repair procedures. H2H repair. Alferi et al. Outlined the rationale for the surgical procedure of H2H leaflet coaptation. They demonstrated that creating a double orifice mitral valve immediately reduces the degree of mitral regurgitation. The advantage of H2H procedure in combination with restricted mitral annuloplasty is that it allows the mitral valve to be targeted directly at the level of the jet of regurgitant flow. The durability of the mitral valve repair can be enhanced and recurrent mitral regurgitation can be avoided by suturing the edges of the mitral valve leaflets close together in the area of regurgitant flow. The Alferi procedure improves results by ensuring early closure of the mitral valve. Before undergoing the edge-to-edge operation, patients should have transthoracic echocardiogram to determine the degree and mechanism of mitral regurgitation and to select the location of the approximating suture. Moving on to conclusions, There is still no agreed strategy to determine how best to manage the patients presenting with secondary ischemic mitral regurgitation. Medical therapy and guideline recommended combination resynchronization therapy with device implementation remain the first line treatment for these patients. Patients should be referred to heart failure referral centers if they are not benefiting from the optimal medical therapy. The care of patients with secondary MR must be managed by multidisciplinary heart team consisting of experts in ha- heart failure, interventional cardiology, arrhythmia cardiology, cardiac surgery, and heart failure management. The team's coordinated work aims to guide the patient through the best available therapeutic pathway. For those with advanced disease and a life expectancy of less than 1 year, and for those with severe comorbidities, referral to palliative care should be considered. The patient's clinical course may be different and not restricted to functional mitral regurgitation surgery. This may require additional interventions such as CABG, management of severe tricuspid regurgitation, and direct mechanical intervention to correct arrhythmias. Although largely driven by retrospective cohort studies, mitral valve repair has long been accepted as the gold standard for clinical benefit. A wheel of controversy surrounding the use of mitral valve repair has been displaced by the findings of CTS-NET RCT, which supports mitral valve replacement in severe MR. Contrary to much of the published literature on this topic, the findings of this seminar assert that mitral valve repair does not necessarily have several uh, uh, advantages over replacement. The literature reports lower operative mortality and improved valve function and higher rates of long-term survival for mitral valve repair. However, patients undergoing mitral valve replacement tend to be older and have more coexisting illness than those undergoing repair. Therefore, adjustment for baseline differences has been critical in non-randomized studies. However, it is important to note that even with the most advanced methods, there still may be unknown or unmeasured risk factors. It is worth mentioning that some studies have found no significant difference in short-term or long-term survival rates between repair and replacement groups, but the majority of studies have favored repair. Valve replacement with caudal sparing improves results compared to previous studies. Retaining the internal architectural support of the left ventricle preserves contractile efficiency and reduces LV dilatation and dysfunction. The lack of durability in correcting mitral regurgitation is a significant concern due to increased risk of heart failure, atrial fibrillation, and the need for repeat intervention and hospitalization. Goldstein findings indicate that patients in the repair group experienced more serious adverse effects related to heart failure and were readmitted to hospitals for cardiovascular causes. The results of Minnesota Living and Heart Failure Questionnaire were consistent with clinical events and they were not inconclusive. Likewise, a meta-analysis compared the use of subvalvular procedures plus restricted mitral annuloplasty to mitral annuloplasty alone and found that adding a double-stage level repair, which includes treating of the papillary muscle, resulted in significant lower frequency of mitral regurgitation. Our meta-analysis indicate that mitral valve replacements is linked to higher early mortality rates but lower reoperation and readmission rates compared to restricted mitral annuloplasty for moderate to severe secondary ischemic mitral regurgitation. For the subset of patients at high risk of adverse left ventricle remodeling or relapse of mitral regurgitation, mitral repair is not warranted. For patients with minimal LV geometric deformation, LV EDD less than 60 and LV ESG less than 55, tenting height between 5 to 8 mm, restricted mitral annuloplasty is advised either with or without anterolateral augmentation, provided that full revascularization of the ischemic myocardium is also achieved in case of extensive post-infarct scarring. The spread of the infarct area into the lateral territory supplied by the circumflex artery usually results in more extensive scarring, which is responsible for increased apical teetering. In such cases, stenting height will exceed 8 mm, limiting the potential for successful restricted mitral annuloplasty. A composite procedure with two-stage level repair of the valvar, that is restricted mitral annuloplasty, and subvalvular, that is surgical valve repair components of the mitral valve is indicated. It is important to note that in addition to restricted mitral annuloplasty, other surgical techniques that may be considered in this setting include edge to edge technique and the ring plus ring technique. In patients with moderate secondary ischemic mitral regurgitation, restricted mitral annuloplasty should be used in combination with CABG surgery if there is extensive post-infarct scarring, especially if surgical valve replacement is required due to accentuated geometrical ventricular deformation such as apical leaflet teething. For patients with ischemic, secondary ischemic mitral regurgitation and a positive LV remodeling, CABG surgery alone is advised. In patients with mitral regurgitation severity proportional to degree of LV enlargement, interventions targeting mitral valve are unlikely to be successful as they do not address the primary pathology. There has been increased interest in subvalvular apparatus surgery, such as papillary muscle augmentation and papillary muscle sling, as the result of the need for a more holistic approach to treating mitral regurgitation that includes both the mitral valve and left ventricle with subvalvular apparatus. These procedures aim to relieve the geometric stress on the left ventricle and the valve teethering caused an asymmetrically dilated LV. Considerable effort has been dedicated to determining the optimal level of annular restriction required for mitral annuloplasty, taking into account the potential risk of stenosis, systolic anterior motion, and recurrent mitral regurgitation associated with overcorrection or excessive undersizing. Biomechanically undersizing the annulus would result in forces on the heart's fibrous skeleton that would oppose the expected displacement vectors relative to left ventricle dilatation in these patients. The imbalance of internal forces within the ventricle can lead to recurrence of mitral regurgitation. The stress on the mitral valve after surgery can be calculated as difference between the preoperative and the postoperative mitral annulus diameter divided by the ventricular and diastolic diameter. This calculation results in mitral annulus stress index, which is an easily measurable clinical indicator for the geometrical changes to mitral valve after annuloplasty. Mitral annular stress index has shown to predict the recurrence of mitral regurgitation after repair. Additionally, the more mitral annulus is restricted in context of dilating left ventricle, that is high mitral valve stress index, the greater the mechanical stress on the mitral valve left ventricle unit, which can have negative long-term outcomes. It appears that the most important predictor of prognosis in secondary ischemic mitral regurgitation is the ability or the residual capacity of the LV to positively remodel, and the uh, and IPMD could be considered in this context as surrogate, that is papillary muscle distance, interpapillary muscle distance, so indicating the entirety of such remodeling. Unfortunately, in the context of percutaneous mitral intervention, it is difficult to establish degree of annular restriction exerted by the mitral clip and its impact on LV geometry. In this context, the use of mitral clip procedure is recommended in patients who with a disproportionate secondary mitral regurgitation in which severe MR is associated with non-severely dilated LV chambers. It is great challenge to manage ischemic mitral regurgitation. The evaluation of ischemic mitral regurgitation can be accurate by perioperative transesophageal echocardiography. Surgical revascularization alone with CABG is sufficient in patients with mild mitral regurgitation, but in cases with severe ischemic mitral regurgitation, CABG along with valve repair can improve functional capacity, LV reverse modeling, MR severity, and BNP levels. The role of concomitant repair in case of moderate ischemic regurgitation is still not clear. The ischemic mitral valve is repaired during CBG with the use of undersized complete rigid ring annuloplasty. Subvalvular techniques may be added in addition to annuloplasty for the correction of ischemic mitral regurgitation. MVR and total, that is mitral valve replacement and total caudal preservation is probably the treatment of choice in severe and complex ischemic mitral regurgitation. Here in the table, we can see the effective uh, an MR classification and the clinical implication it will have. Effective regurgitant orifice area divided by left ventricular end diastolic volume can give us the ratio. If it is more than 1.6, the MR is classified as severe disproportionate, and the clinical implication is that intervention of the mitral valve will be beneficial. If it is 1.1 to 1.6, that is severe proportionate, intervention of the mitral valve may not be beneficial. And if it is less than 1.1, that is non-severe, intervention of mitral valve is not indicated. The following decision make algorithm for decision making in patients with mitral regurgitation due to ischemic cardiomyopathy myopathy can be derived from the following articles. So, patient once identified as ischemic mitral regurgitation and then classified into severe, then it further classified as persistent symptoms with severe MR and undergoing other cardiac surgery. If it is end stage of heart failure, then surgery is not indicated and medical heart failure techniques and palliation is required. And recommended intervention for mitral valve surgery in cases of uh, in which favorable that is TT value and BSA and that is favorable anatomy, mitral valve repair is recommended, and with poor anatomy mitral valve replacement is recommended, and very high surgical that is high surgical risk patients mitral clip is recommended. Thank you.
Yeah, okay, Shreyas. This is a very important topic, and I am disappointed that there are no consultants who are actively practicing these things on day-to-day basis are not attending. The first thing that you all must know is in ischemic MR, the pathophysiology is coronary artery disease.
Yes, sir.
So there is a deficiency of blood supply, especially to the papillary muscles, either the anterior or the posterior or both, and that causes mitral regurgitation. So that is the primary thing. So in whatever you do in ischemic MR, CABG or for some sort of revascularization by way of angioplasty or stenting has to be the primary treatment. Okay,
Yes.
you cannot do anything. CABG is the primary treatment to combat ischemic MR. So that is something that you must remember. Secondly, as I always tell you all, any procedure you have to evaluate as when, how, when not, complications, results, and then the outcomes. So when where you kept on saying about the mild, moderate, and severe MR, and mild, moderate, and severe MR is does not mean anything. There has to be quantification because because when there is ischemic MR, there is global hypokinesia. The LV geometry is distorted, and it becomes
Yes.
a globular sac.
Yes, sir.
So that causes problems with contraction. So one, you are going to set that right by doing a little by revascularizing that and then allowing that ventricle to remodel itself. So once there is an infarct or there is a problem, there it will never come back to the original conical shape of the LV. It will still be a globular portion. And that is
Thank you,
the
sir.
reason why you are going to do these various other procedures, like the restricted mitral annuloplasty or subvalvular repairs or the mitral valve replacement, depending on the severity of MR. So the
Mm.
first thing that you all should understand is how to assess which requires mitral valve surgery and which cases don't. You can leave them alone only with a CABG. CABG is the primary thing that you have to do in ischemic MR. Understand that.
Yes.
Okay, so for that, I think in one of your slides in the later, in the end, you put up this thing about regurgitant orifice area versus the LVDD
Yes, sir.
ratio. That may be an important thing to decide whether you're going to tackle the MR or just leave it alone. Okay, so that is
Yes, sir.
something that you all should have it very clear in your mind. Which are the cases you are going to address the MR, and which are the cases you are not going to address the MR.
Yes, sir.
Now coming to the LV dimensions is an important thing, and the LV thickness and the dimensions are important in assessing preoperatively. The next thing important is in the RMA. You said normally the what was taught to us was that you should reduce the annulus size by 2.
Two. Yes, sir.
Right. The other important thing is you should know whether you are going to use a rigid ring or a semi-rigid ring or a flexible ring.
Flexible.
Generally, the teaching used to be, I'm not too sure whether you will have to check on that. Ischemic MR, because you are going to be remodeling the annulus and then give a scaffolding for the LV to contract. Rigid rings were the preferred thing, I think, that in those days. So you have to check on that whether you're going to use a rigid ring, semi-rigid, or a flexible ring. That is
Flexible.
something
Okay.
that you have to find out from your
Okay, sir.
consultants and what are the things.
Yes,
Second,
sir.
so that is one thing, because that is also the reason why you preserve the subvalvular apparatus, preserve the Cody, so that the global geometry, the LV geometry, is preserved. Understand?
Yes, sir.
So that is the importance of the ring. Then of course you mentioned about all the other subvalvular repairs, like repositioning and then relocation and ring and string techniques. Now MVR is generally recommended for, that means replacement is recommended for severe MR. The
Severe.
reason
Yes.
being, these patients are very sick. They cannot tolerate something which is suboptimal. You do a repair and it fails, then you cannot go back again on pump and other things, and then do the repair, and then the pump time will be very
Yes.
long,
Okay.
and the recovery is not going to be optimal. So in such a situation, MVR is the straight thing, first thing to do. However, as you rightly said, because they are very sick patients, the immediate operative mortality will be much higher than the
In the
other
repair.
cases. Although
Yes, sir.
if they survive the immediate perioperative period, the long-term results are a little better with
Yes, sir.
severe MR and having an MVR. So these are the few things that you should know. And I wish you had talked about what is our own practice in NH. So you should have talked to some of the consultants. What do we do? How do we decide when to intervene onto the mitral regurgitation? When will we leave it alone? What are the procedures that are generally followed? These are things that you should have talked about a bit. And
Yes, sir.
yes, and I'm quite disappointed that some of the consultants are not joining these programs or classes, so that they could educate us what are the recent and current trends that are happening. Okay,
Yes, sir.
so these are few things that you should go back and check with the
Yes, sir.
consultant, and then
Yes, sir.
also tell your colleagues as well.
Yes, sir.
Any other questions anybody has? I see only the junior most people are attending this. Oh, Akshay Deshmukh, he's joined much later. I think you missed the whole class, I think, Akshay.
Yes, sir. Last week just finished the case, so
Yeah, okay. Anyway, it's all right. Anyway, you can educate them on these questions that I've asked.
yes, sir.
Okay. All right. This is a very important topic. Okay. Ischemic MR is a very
Yes.
important topic, and the decision making,
Yes, sir.
especially when you are doing just a CABG or a CABG with just a repair or CABG with
And
MVR,
NPR.
this decision has to be taken before taking up a case like this. So,
Yes, sir.
so you must have a very clear cut idea of what you're going to do with your patient. Okay.
Yes, sir.
Yeah. Thanks.
Thank you, sir. Thank you.